My name is Michael Müller-Nilsson, and I am a physiotherapist and specialist in musculoskeletal and sports physiotherapy. I am also the National Director of the Mulligan Concept in Denmark and an accredited member of the Mulligan Concept Teacher Association. I work clinically, I teach, and I spend a lot of time thinking about why good treatment sometimes fails, even when the tissue looks fine. Let's begin where the brain actually began. In this episode, we will dive into the topic pain, nociception, and the limits of the brain-only pain narrative. The last couple of years, there has been a heated debate regarding pain. Is pain only in the brain and generated by internal processes of the brain, or do we need activation of the nociceptive apparatus to experience pain? So let's begin. Why this debate matters. Today's episode is a deep, critical discussion of one of the most influential and controversial questions in contemporary pain science. Is pain primarily a construct of the mind, or does pain require activation of a nociceptive apparatus? This question is not abstract. It shapes how pain is explained to patients, how clinicians justify treatments, how responsibility for recovery is framed, and how uncertainty is handled in clinical encounters. Over the last 2 decades, pain science has undergone a profound conceptual shift. Pain is no longer taught as a simple signal from injured tissue. Instead, it is increasingly described as a perceptual experience generated by the brain, informed by prediction, learning, context, and perceived threat. This shift underpins pain neuroscience education, biopsychosocial rehabilitation, and therapies such as cognitive functional therapy. It has changed how clinicians speak to patients, often emphasizing reassurance, safety, and the idea that pain does not necessarily mean damage. At the same time, a growing body of scholarly critique argues that this pendulum has swung too far. According to these critics, pain science has quietly adopted an assumption that is neither empirically demonstrated nor conceptually coherent, that pain can occur without nociception. Today, I will walk through 2 opposing conceptual positions, examine their evidence, and explore what this means for pain management and pain neuroscience education. Position 1. Pain as a brain-based construct. Let's start with the dominant contemporary view. Modern pain science often frames pain as an output of the brain, not an input from tissues. According to this view, nociception is neither necessary nor sufficient for pain. This idea appears repeatedly in educational frameworks, clinical guidelines, rehabilitation models, and popular pain science narratives. The argument begins with an observation that is undeniably true. Pain correlates poorly with tissue damage. People can have severe structural pathology with little or no pain. Others can experience intense disabling pain in the absence of identifiable tissue injury. Imaging often fails to explain symptoms. Pain fluctuates with stress, mood, context, and expectation. From this, a stronger claim is often inferred. If pain does not reliably map onto tissue damage, then pain must be constructed centrally, as a prediction or inference about threat. In predictive processing accounts, the brain integrates sensory input with prior beliefs, expectations, and contextual information. Pain is produced when the brain concludes that protection is necessary. Nociceptive input may contribute, but it is not decisive. This framing has been enormously influential in clinical practice. Pain neuroscience education teaches patients that pain is about protection, not damage. Cognitive functional therapy focuses on changing beliefs, reducing fear, and normalizing movement. Success is often measured in reduced disability, increased confidence, and improved participation, sometimes even when pain itself persists. At a pragmatic level, many clinicians recognize the value of this approach. Patients often feel less afraid, more capable, and more willing to move. But embedded within this model is a strong ontological claim that pain can occur without nociception, and that claim is rarely examined carefully. The evidence problem in brain-only pain claims. When advocates of pain as a brain construct argue that nociception is unnecessary, they typically rely on a familiar set of examples: phantom limb pain, placebo and nocebo effects, pain induced by expectation or context, pain in the absence of identifiable pathology. At first glance, these examples appear compelling, but when examined closely, They fail to demonstrate what they are often claimed to show. Phantom limb pain is frequently cited as proof that pain can arise without any peripheral input, yet detailed neurophysiological investigation shows ongoing activity in peripheral nerves, dorsal root ganglia, spinal cord circuits, and cortical representations. The nociceptive apparatus remains active even if the limb is absent. Placebo and nocebo effects do not eliminate nociception, they modulate it. Endogenous opioids, descending inhibition, and attentional mechanisms alter nociceptive processing, but the system being modulated is still biological. Experimental pain illusions typically rely on subtle sensory input, expectation, or demand characteristics layered on top of ongoing afferent signaling. They demonstrate modulation, not creation from nothing. Most importantly, the absence of identifiable tissue damage is not the same as the absence of nociception. Biological processes can generate nociceptive signaling without producing lesions visible on imaging or routine clinical tests. This distinction is repeatedly blurred in education and clinical reasoning, and that blurring leads to conceptual overreach. Position 2. Pain requires a nociceptive apparatus. Now let's turn to the opposing position. Critics such as Weisman, Quintner, and Cohen do not deny that pain is subjective, contextual, or influenced by cognition. What they deny is the claim that pain can occur without nociception in any form. Their central argument is simple. There is no convincing empirical evidence of pain arising in the complete absence of nociceptive apparatus activation. To make this claim workable, nociception must be reconceptualized, not narrowly as nociceptor firing due to tissue injury, but as activation of a distributed nociceptive apparatus. This apparatus includes peripheral afferents, spinal cord modulation, supraspinal integration, immune and glial signaling, and neuroendocrine and stress-related mechanisms. Under this framework, nociception can be diffuse rather than focal, ongoing rather than event-based, and systemic rather than local. This reconceptualization resolves many apparent paradoxes. Chronic pain can be biologically grounded even when imaging is normal. Nociplastic pain does not require abandoning biology. Central sensitization becomes a feature of nociceptive processing, not an alternative to it. Most importantly, this position preserves a crucial distinction. Nociception is necessary, but not sufficient for pain. The brain interprets, amplifies, suppresses, and contextualizes nociceptive input, but it does not replace it. Pain management and the limits of pain, neuroscience education. This brings us to pain management. Pain, neuroscience education, and cognitive functional therapy are often presented as theoretically grounded in modern pain science. Yet when outcome data are examined critically, a more nuanced picture emerges. Across trials and systematic reviews, effects on pain intensity are typically small, inconsistent, or uncertain. Disability and function often improve more reliably than pain itself. This pattern matters. Improved function does not prove that pain was primarily cognitive. It may reflect better pacing, confidence, coping strategies, or task tolerance, all compatible with ongoing nociceptive input. There is also a persistent validation gap. We lack strong evidence that teaching pain neuroscience concepts, changing beliefs about pain, or increasing clinician confidence in biopsychosocial reasoning leads to reliable reductions in pain across populations. Educational interventions are often evaluated using internally aligned outcomes, reinforcing their own theoretical assumptions. Finally, there are ethical implications. When pain is framed primarily as a false alarm or perceptual error, responsibility subtly shifts toward the patient. Persistent pain may be interpreted as a failure of understanding, belief change, or engagement. This risks invalidation, even when unintended. A nociceptive apparatus framework avoids this trap. It allows clinicians to acknowledge uncertainty, retain biological plausibility, and support patients without implying blame. Synthesis and summary. Let's bring this together. Pain is not a simple signal from damaged tissue, but pain is also not a free-floating construct of the mind. The evidence supports a biologically grounded position. Pain emerges from the interaction of nociceptive signaling, neural processing, learning, context, and meaning, but it remains anchored in biology. Reconceptualizing nociception as a distributed apparatus allows us to explain chronic and nociplastic pain without mysticism, avoid false brain-body dualism, teach pain science honestly, and practice ethically. Pain neuroscience education and biopsychosocial therapies may still have value, but their theoretical claims must be more restrained than their rhetoric. Pain does not need tissue damage, but pain does need nociception. Thank you for listening. I hope you found this episode useful. My name is Michael Müller-Nielsen. I am a physiotherapist specializing in musculoskeletal and sports physiotherapy and an accredited member of the Mulligan Concept Teacher Association. If you'd like to share your experience or follow future content, you can subscribe to the Mulligan Concept Denmark on YouTube and Facebook. More information about courses in Denmark is available at mulliganconcept.dk.